Hello, Tess. Good afternoon, everyone. Can you hear me?
Yes.
Yes, I
Thank
can hear you clearly.
Thank
Yes,
you.
we can hear you.
Now we are waiting for friends to come in. And we will start our webinar shortly.
Right.
For Thai pharmacists, please change your display name to the same name as you use in registration to verify the CPE credit. สำหรับเภสัชกรทุกท่านนะครับชาวไทยทุกท่านนะครับให้เปลี่ยนชื่อที่แสดงที่หน้าจอนะครับให้เป็นชื่อเหมือนกันกับที่ลงทะเบียนไว้ด้วยนะครับเพราะว่าเราจะแคปเจอร์หน้าจอเพื่อนำไปให้หน่วยกิจ CPE นะครับขอบคุณครับ
聞こえないよ。
Okay, everyone, we will begin now. Good afternoon, everyone. My name is Thirapong Sisin. I'm an assistant professor of pharmacy practice at Mahasarakham University, Thailand. It's so great to see you all this afternoon, and I'm very happy and honored to be host for today. Welcome to the second webinar, Evidence-Based Pharmacotherapy in Heart Failure and Pharmacist Role in ASEAN Countries, which is a big one of our webinars because we have 377, almost 400 participants joining us this afternoon. Okay, I think we are ready to enjoy learning with our great speakers from Thailand, Philippines, and Malaysia. First of all, let me bring you to the opening ceremony with a brief welcoming speech from audience or representatives. Now, I would like to invite Assistant Professor Dr. Chenatha Phayuamsang, Dean of the Faculty of Pharmacy, Mahasarakham University, Thailand, to say greetings and welcoming to everyone.
Good afternoon, everyone. Dear distinguished guests and all participants, I would like to welcome you to the opening ceremony for the second webinar, Evidence-Based Pharmacotherapy and Pharmacist Role in Heart Failure in Asian Countries. This is a special occasion, I think, because there's a lot of people who join with us. I have heard that we have allowed six countries from no, not six, just nine countries to give or participate in this webinar. We have distinguished guests as a dean from 5 universities to join with us. As we know that heart failure is a major leading cause of death in people around the world, and we need a good practice and evidence-based for treatment. And I think pharmacist is in a good position and role for pharmacotherapy in this area. So I think it will be a good time for us to learn from the specialist or the practitioner in this area, our pharmacists who practice in this area, to give us a lecture about pharmacotherapy in heart failure. And I would like to thank for all of you to join with this, because it's the webinar could not be happened without all of you to join with us, or to have a good collaboration and partnership from all universities to join together. So more than that, I would like to thank for all participants who join or give participation and your time arrangement for this webinar. I am hopefully that you will enjoy this webinar and gain knowledge from our specialists from 3 countries, and have a good time, and hope to see you in the next webinar. Thank you for joining.
Thank you, Dr. Chenatha, so much. And next, I would like to invite Dr. Charles Mandy Aaron, representative of Dean of the Faculty of Pharmacy, University of the Philippines, Manila, to say greetings to everyone. Please, Dr. Charles.
Hi, thank you, Dr. Thirapong. On behalf of our Dean, Dean Bienvenido Balotro of the University of the Philippines, Manila, I would like to congratulate in advance Mahasarakham University for once again organizing this webinar for the purpose of helping the continuous development of our pharmacists, usually from the Southeast Asian region and also from other parts of Asia. So I actually remember that years ago, we started our collaboration through our exchange programs for our students. And I'm very happy to see that we are still continuing our partnership in order to develop more pharmacists who are capable, competent, and confident in delivering pharmaceutical care. So I would like to greet everyone from all of the countries, as well as our different universities present in today's event. So good afternoon, everyone.
Thank you so much, Dr. Charles. And I would like to invite Professor Hiroyuki Itabe from Showa University, Japan, to say greetings to us. Please, Professor.
Hello, hello everyone. I'm Hiroyuki Itabe from Showa University. Today, I'd like to thank all the members in Mahasaka University for organizing such a nice webinar. And also, I'd like to thank the collaboration with Mahasaka University for many years. We have been doing the exchange programs for years, and hopefully we can restore such actual activities as well as webinar programs in the near future. Today, I'd like to enjoy the webinar to join many people in the ASEAN countries. Thank you very much.
Thank you so much, Professor Itabe. And we also have Dr. Sunanta Suwanlasi, Dean of the Faculty of Pharmacy, University of Health Science, Lao PDR, for welcoming us.
Thank you, Dr. Chirapong. Distinguished guests, ladies and gentlemen, my name is Sunanta Suwanlasi. I would like to express my sincere thanks to the Faculty of Pharmacy, Mahasarakham University, that give me the opportunity to speak today. I'm great to have the academic collaborate for several years, and we have developed our several pharmacist capacity through that cooperation. I'm very grateful that we continue to further cooperation in the future. I wish the webinar on evidence-based pharmacotherapy in heart failure and pharmacy loan in ASEAN country today have a good July.
Okay, thank you, Dr. Sunanta, so much. And also, I would like to invite Dr. Nurolaini Kifli, Head of the Pharmacy, University Brunei Darussalam, to say greetings.
Thank you very much, Professor Terapong, the chairperson. I would like to, I'm Dr. Nurul Aini Kifli from University Brunei Darussalam. Actually, this is our first collaboration, and thank you very much for the invitation. First and foremost, I would like to congratulate the organizer and extend my warmest appreciation to the host for this webinar, the Faculty of Pharmacy, Mahasarakham University, MSU in Thailand, for organizing this webinar today entitled Evidence-Based Pharmacotherapy in Heart Failure and Pharmacist Role in ASEAN Country. And thank you for including us as well in this collaboration. So as we know, heart failure is a clinical syndrome that has huge impact on the hospitalization and mortality of the patients. So according to recent studies in 2020 as well, suggests that most Southeast Asian, we are at a very increased risk of having heart failure, and it presents at an earlier age than in most other racial or ethnic groups. So there is also evidence to suggest that we use less of the guideline recommended for the heart failure medical and devices therapy in Southeast Asia. Therefore, this webinar is to address such issue is timely, especially on the role of pharmacists to help flatten this curve of increasing number of heart failure in the coming decades. there is an urgent need to curb this rising trend, particularly through policy action and strengthening our healthcare system and optimizing the management of prevalent in heart failure in particular. So University Brunei Darussalam, our university, is also collaborating with MSU in this important global collaborative ASEAN effort, especially in the prevention and management of NCDs as part of this effort. So I do aspire we can strengthen our effort as an ASEAN community to achieve our motto, one vision, one identity, one community. I wish we will learn new knowledge and information from each other from this webinar, and I hope everyone will have a fruitful and also fun session this afternoon. Thank you very much.
Thank you so much, Dr. Nurulaini. And we also have Dr. Devi Sejaningsi, Vice Dean of the Faculty of Pharmacy, Sanata Dharma University, Indonesia. Please, Dr. Devi.
Yes. Good afternoon, everyone, and we are happy to be here. It is an honor for us to be invited in this second webinar, and we greet all of you and hope that this seminar will be at the moment of giving us experience share together here, and we can learn each other. So between Mahasarakam University and my university is already in a collaboration, and we now continue in a research collaboration and also student activity. And we are happy to be here to join in this seminar. And we believe that in this seminar, we will learn much more about from the expertise, how to tackle and also the role of pharmacists in the healthcare view. So thank you very much and hope this seminar will be successful.
So thank you so much, Dr. Devi. And next, I would like to invite Dr. B. Kim from Taylor University, Malaysia. Please, Dr. B. Kim. Sorry, we can't hear you.
Sorry, can you hear me, Dr. Terapong?
Yes, okay.
Yeah. Thank you very much, Faculty of Pharmacy, Masarakam University, for inviting Taylors, to participate in this meaningful webinar. And it's our pleasure to see academics and practitioners, from many ASEAN countries sharing experiences and expertise in managing patients with heart failure. So I look forward to a successful and enriching webinar. Thank you.
Thank you so much, Dr. B. Kim. And I would like to invite Dr. Nguyen Thi Tu Phong, from Dean from Hai Phong University, Vietnam. Say greeting to us.
Yeah, thank you. Hello, everyone. Thank you for inviting me to join this webinar. So nice to see all of you today. I'm blessed to continue the cooperation activity between the Faculty of Pharmacy of Mahasarakam University and Hai Phong University of Medicine and Pharmacy, including exchange of lecturers, students, education and research. Training activity on skills and professional knowledge for clinical pharmacists are extremely necessary and meaningful. I wish this program and our cooperation have great success. Thank you again.
Thank you so much. And we also have Dr. Nguyen Thi An Phong, Dean from Huế University, Vietnam. Oh, okay. Okay, thank you. Okay, thank you to our dean or representative and professor for welcoming us. I think we should start now, and we begin with the first session, evidence-based pharmacotherapy in heart failure. Let me introduce our first speaker. Assistant Professor Dr. Arilat Lilatana or Dr. Apple. She got to Doctor of Pharmacy with honors from Mahasarakham University and University of Maryland. She completed her postgraduate Year 1 Pharmacy Residency Program and Year 2 Internal Medicine Pharmacy Residency Program at Banner University Medical Center, University of Arizona, USA, and got her board certified pharmacotherapy specialist in 2016. Now she is Associate Dean of Academic Affairs of the Faculty of Pharmacy, Mahasarakham University. Please welcome Dr. Apple.
Good afternoon, everyone. I'm not sure if you can hear well, can hear me clearly.
Yes, we can hear you with a clear voice, Dr. Apple.
All right. Good afternoon, everyone. It's an honor for me to join this webinar. And thank you so much for inviting me and have me here today. So I'm going to talk about evidence-based pharmacotherapy in heart failure. And I know someone already mentioned this is a important problems in ASEAN, in Asia, in this world as well. So let's get started. For this talk, I have nothing to disclose, and these are my learning objectives for today. So hopefully at the end of this presentation, you guys should be able to list medications that reduce hospitalization, prolong survival for patients with heart failure with reduced ejection fraction or HFrEF, and discuss the treatment options for heart failure with preserved ejection fraction or HFpEF. It's quite difficult to pronounce this one, but this is the one that I'm going to talk about. And finally, we're gonna summarize the current guidelines for heart failure management. And the one that I'm focused right now for today is I'm going to talk about ASC 2021 that published last year, and also focus on new medication that's just approved for heart failure like SGLT2 inhibitors. So why we need to care about heart failure? If you look at this condition, it's just associated with substantial morbidity and mortality. There is a projection that they estimated that the prevalence of heart failure will increase 46% from 2016 to 2030. And when we look at the death rate for the patient, it remains high. We can say like almost 50% of patients who got diagnosed with heart failure, they may die within 5 years. And if you look at the rehospitalization rate here, you can see here that we found like almost 25% of patients may come back to hospital readmitted again within 30 days. So this cause a financial burden to healthcare system, to healthcare workers, and also for patients themselves, this also decrease quality of life. And that's why I think it's so important for pharmacists, for clinicians to understand the management of heart failure. And you can see previous evidence supporting that pharmacists play a crucial role in the management of heart failure. We can prevent rehospitalization. We can decrease the drug-related problems. We can improve medication adherence for heart failure patients, and definitely we can improve quality of life for patients as well. So that's why we need to talk on this topic. And when we talk about heart failure, it's just about the pumping and feeling problems. You can see when patients have this problem, this can lead to the reduction of cardiac output. You can see here, and that can lead to the reduction of perfusion in the body and organ. Patient may present to you with fatigue, couldn't breathe. They may have like fluid accumulate in the lungs, and they have legs swollen, something like that. And that's very important that for us to interview, to ask patient comprehensively so that you can see the overall for the patient. And based on the new guideline for 2021 ESC guideline, they proposed a new term that I think we should know about is heart failure with mildly reduced ejection fraction. It is the patient who has ejection fraction between 41 to 49%. And we still have the same definition for reduced ejection fraction here, like less than or equal to 40%, and preserved ejection fraction refer to patients who have ES like 50% or above. The thing is, we need to know this one, because you can see if we know the number of this one, you can choose the appropriate medication for patient, because we know that we have medication that can prevent death for HFrEF patient. However, I think it's also important for this guideline. They mentioned that heart failure is not single pathological diagnosis. It's a clinical symptom. You not just treat the number, but you need to look at the patient as a whole and try to taking care individual patient as well. And given heart failure is a serious condition, so you can we try to help patients to achieve the following goals. Like we try to decrease mortality, decrease hospitalization symptoms, improve quality of life, and try to decrease the disease progression. HFrEF, we have that. We have medication that can help us to achieve these goals. But for HFrEF, HFpEF, sorry, we still don't have much information about medication that can do that. But however, last year, we have new group of medication class like SGLT2 that may help in terms of mortality benefit. And I'm going to talk about that. And this picture, I just want to give you like a timeline for heart failure management. I think it's so fascinating to see this one. You can see from like start that we have just medication to help for sign and symptom improvement, but now we have more medications that help to prevent death, decrease hospitalization, or we have device that can prevent patient from sudden cardiac death, something like that. And now last year we have other new class of medication that can also help further decrease mortality for patient. So before I get started to the new guidelines, so I think it's a good idea to just go back and look at the previous guideline a little bit. This is from AHA guideline 2017, and I look at like 2016 from ESC, also the same. The main key medications that kind of like a foundation of treatment for heart failure with preserved ejection fraction include like ACE inhibitor. Sorry, it's just with my slide because I try to put on a pen, but sometimes it's just click. Sorry about that. And we have like ACE inhibitor, ARB, ARNI. You can either pick one of them, and plus beta blocker, the second one. And also if patient doesn't have any contraindication, you need to add a third medication like aldosterone antagonist. And that guideline also mentioned about ARNI. And ARNI, if you remember, like from Paradigm HF trial, this one we recommend in replace of ACE inhibitor or ARB. We use if patient can tolerate ACE inhibitor before switching to ARNI. So that kind of like a picture from previous guideline. And other than that, we just treat patient based on sign and symptom of them, like give diuretics, something like that. Now let's move to the current guideline from the ESC 2021. Now you can see like we don't have just 3 medications anymore, not just 3 group of medication. We have new groups of medication like SGLT2 inhibitor now are one of the foundation treatment for patients with HFrEF. Besides RAS inhibitor, beta blocker, aldosterone antagonist. So these 4 medications just form the evidence base and provide benefit for heart failure patients. And if patient, like if you look down here, you can see you can give other medications like diuretics. The same can help to reduce signs, symptoms for patients. And the important thing for this guideline, they also try to mention in terms of the phenotypic approach for each patient. When we say that, it means like we try to give or take care specific problem of the patients, like comorbidities or compelling indications, something like that. Like you want to give additional drug for patient if they need it. For example, if patient has atrial fibrillation here, you need to give anticoagulant for patient, right? And you may consider add digoxin for patient for like rate control, and that may help for prevent rehospitalization for patient. And or if patient has like very high heart rate here, even though they receive maximum tolerated dose of beta blockers, you can give ivabradine for patient. So I think that is a good concept that we need to think about comorbidities for patient and try to give medication that the patient really needed. And if I try to like explain more in terms of recommendation, you can see here all 4 medication class as level 1 recommendation, which means it's recommended. Like they are recommended for heart failure patient if they don't have any contraindication. And I want to straight a little bit here about sacubitril/valsartan. You can see here this we can give replace for ACE inhibitors, and you can give ARNI. Now, based on this guideline, you can use for ACE inhibitor naive patients, like the patient who never used ACE inhibitor before. You can give that medication to patient. This is based on the Pioneer SF open label extension. This a randomized controlled trial study, and they this is designed for like evaluating the effect of sacubitril/valsartan compared to enalapril in patients who admitted in hospital for acute decompensated heart failure. And after that, after patient have hemodynamic stabilization, you can start patient on either enalapril or sacubitril/valsartan. After 8 weeks here, we can like the trial just switch patient who got enalapril to sacubitril/valsartan. The primary endpoint, they look at the changes in the NT-proBNP from the baseline. You can see here the NT-proBNP levels decline to a greater extent for those switch from taking enalapril to sacubitril/valsartan. And that's kind of like a surrogate marker. You may ask about clinical outcomes here. And when we look at on the right side here, you can see another graph over the entire 12 weeks of follow-up patient that began taking sacubitril/valsartan here in the hospital and had a lower composite outcome in terms of CV death and hospitalization for heart failure when compared to the patient who start on enalapril and later switch to sacubitril/valsartan. You can see here we found almost like 20-30% of these patients start on sacubitril/valsartan at the beginning without experience of ACE inhibitor. So that's why we think it seems like giving sacubitril/valsartan early as possible, you have an opportunity to get maybe early benefit from this medication. So this slide, I just want to give you in terms of initial dose of ARNI. So since now we can use like for naive patient, the thing when you try to give this medication, you really need to start with lower dose for naive patients. And also as like patient who have severe kidney function, it's better to start lower dose as well, or even though elderly patients, so that you can monitor them and then titrate the medication. Why we need to start lower dose? I think the common side effects of sacubitril/valsartan, one of them is hypotension. So that's why you want to a little bit like go start low a little bit for this one, and need to monitor blood pressure closely. Angioedema can be found for this medication, hyperkalemia, renal insufficiency. So that's why with patient who has like severe renal impairment, you should start with low dose and use with caution. And we never use ACE inhibitor, ARB, and ARNI together. That put patient at risk for angioedema. So that's why if you want to switch patient from ACE inhibitor to ARNI, you really need a washout period for 36 hours. But for ARB, you can switch like next dose. And another thing is angioedema, so you need to be cautious about that. If patient has experience with angioedema from ACE inhibitor, when start ARNI, you need to concern. We don't have much information, but we know that there is like less than 10% of cross reaction between ACE inhibitor and ARB, but in practice we still use because the benefit of this medication is so high, but you really need to be careful about angioedema as well. So that about ARNI. So I'm going to move to next medication. If you have any questions, anything that you would like to discuss, just feel free to put it in the chat box. Now let's get to the next medication. Now we're going to talk about SGLT2 inhibitors. This kind of like a game changer for like heart failure right now, and many people talk about this one. Like you know, right? SGLT2 inhibitors initially approved for diabetes, but now we just expand the indication for this one, and the indication, the mechanism of action for SGLT2 inhibitor is like inhibit at like SGLT2 transporter here in the proximal tubule, which account for nearly 90% of filter glucose reabsorption in the body. So if you inhibit here, you just exclude sugar from the body, and that's why we use for diabetes. However, based on the trial from diabetes trial, you can see this also provide heart failure hospitalization benefit or cardiovascular outcome benefits as well. So if you ask about how does it work to help for patient with HFrEF, I would say there is no clear answer for that, but we believe that because this medication improve kind of like a kidney function by working on like as osmotic diuresis here, and it also decrease the arterial pressure and stiffness. So that why it may help improve kidney function and also reduce like remodeling in the heart. And based on the trial in heart failure from the landmark trial here, like DAPA-HF, for dapagliflozin here compared to placebo in patient who have ejection fraction 40% or less. This patient already on guideline directed therapy like ACE inhibitor, beta blockers, aldosterone antagonist. We found 26% reduction of composite endpoint, including CV death and hospitalization. So if you look at another kind of twin trial here for empagliflozin from Emperor Reduce, the result is similar to DAPA-HF. You can see here 25% reduction of composite endpoint like CV death and also hospitalization. So this result just like show us that so impressive in terms of the benefit from SGLT2 inhibitors. if you look at the combined result from both Emperor Reduce and DAPA HF, here from meta-analysis here, you can see the results are consistent across the board. Here you can see that the signal here that the drug can improve in terms of decrease all-cause mortality, decrease CV death here, and also decrease hospitalization. If you look at patient in terms of diabetes status here, also see the same result. So it's favor for SGLT2 inhibitor regardless of patient has diabetes or not. So now we recommend for all heart failure patients. So that's why slide here, I give the place and recommendation here based on the guidelines. So guidelines said you can add SGLT2 inhibitors as a part of therapy for patients with HFrEF who are already receiving beta blockers, ARNI or RAS inhibitor, aldosterone antagonist if no contraindication. And the good thing for this medication is you can see the initial dose and target dose just the same, 10 milligrams daily, that's easy to remember. And in terms of benefit of this one, like I mentioned, decrease CV death and hospitalization, also improve quality of life. In terms of consideration, you can see here the problem with SGLT2 inhibitor is we found that initial starting dose, patient may develop mild worsening of kidney function, but that's just the number. It's not effect on the kidney function, and over time it also help to prevent the progression of kidney function as well, so that provide kidney benefit. And since this can worsening kidney at the beginning, so that's why when we start SGLT2 inhibitor based on the ESC guideline, they recommend start if patient has eGFR 20 or above. In terms of side effects, common one is hypovolemia, dehydration. So that's why when you start this medication, you need to monitor fluid status for patient. If patient also on like diuretics, you need to be careful when you increase the dose of diuretics because that may put patient at risk for dehydration. DKA can be found, but it's quite rare. So that's why when you have patient who on SGLT2 and has diabetes, you may like educate patient like you need to eat. If you cannot eat, you need to like monitor sign symptom, you need to drink, something like that. Amputation is quite rare. Based on clinical trial, it's quite similar to placebo group. And the big one is genital urinary infection here that we found many patients on this one may have infection in that area. So that's why if you think about mechanism of action, it makes sense, right? Because you excrete a lot of sugar into urine, and that you just make urine become like culture medium for bacteria to go. So that's why hygiene measure is so important for this patient, and you really need to educate them. And when we look at the patient here, I just have a quick question here, but the thing that I would like to say is home medication for this patient, like this is 55 years old, female, referred to clinic after got diagnosed with heart failure with reduced ejection fraction. Patient has symptoms like New York Heart class 2. Other than that, like lab is just look okay, except serum creatinine. Patient on carvedilol, enalapril, furosemide, statin, aspirin. So you can see this is of many patients that we found in the clinical practice. They not get the full course of comprehensive guideline-directed therapy, So the thing is, if you cannot help patient to get to like comprehensive disease-modifying pharmacotherapy, that can make patient not get the best outcome from that. This is the study from Lancet 2020, and they try to look at the treatment with the comprehensive medication like RAS inhibitor plus beta blocker, aldosterone antagonist, and also SGLT2 inhibitor compared just receive ACE inhibitor and beta blocker like previous patient. You can see here in the blue line refer to comprehensive medication risk, and the red line here refer to the conventional only ACE inhibitor and beta blocker. We found significant improvement with the comprehensive therapy in the event-free survival. And I would say like there was estimated that patient will get around 8.3 additional years if they can get all 4 medications. So that's so important as a pharmacist to help patient to achieve this one. And the question is, and how we can get the 4 medications? I think that the thing that's in terms of initiation sequence, you can either start with any one of RAS inhibitor, beta blockers, or ARNI, you can either pick one of that, or SGLT2 inhibitor. The thing is, you try to get to the target dose. That is so important. But there also is concern about if you start like quite slow, that make patient get later benefit, you not get early benefit, you know. So some people try to say like, avoid too little, too late. What does it mean? The thing is, we have underutilization of the guideline-directed medical therapy a lot. Real-world data, I know someone mentioned this already, like we have only 60 to 80% of patients got ACE inhibitor and beta blockers, and only 30 to 60% got aldosterone antagonists, and ARNI only 10%, you know, like it's so low, and I think that may be related to cost as well. And the big concern that many clinicians doesn't want to add 4 medication, they just concerned about side effects, concerned about polypharmacy, but that you also prevent patient to get good medication as well. And some people try to introduce simultaneous initiation of HEP-REP therapy, like you start all 4 medication at the same time, or not just one medication as conventional, and you can try to titrate every 1 or 2 weeks. That may help patient to achieve 4 medication within maybe 4 to 6 weeks, something like that. And the result quite reasonable, and it's safe to do that as well. So this slide, I just want to summarize all medication that you can use for HEP-REF. So like ACE inhibitor, ARB, ARNI, beta blocker, aldosterone antagonist, and SGLT2 inhibitor. You can give for all patients. Like for ARB, you use in replace for ACE inhibitor if they cannot tolerate ARNI in replace of ACE inhibitor or ARB. I didn't mention about vericiguat here because I don't have time, and this already like 26 minutes. But this is another new medication that they work as an oral soluble guanylate cyclase stimulator. They enhance the cyclic GMP and increase nitric oxide. They found the results show that this may help to reduce severe death and hospitalization in patients who have symptoms. Like high symptom, have worsening heart failure, you may give that to this patient as well. But all right, so and next one, I'm just gonna go very quick about heart failure with preserved ejection fraction. I think it's just so it's just like we're going to talk about the medication that play a role a lot. And usually for HEP-PrEF, you just treat patient based on sign and symptom. Taking care risk factor, we don't have medication that show mortality benefit. Until last year, we have SGLT2 inhibitors that if you look at the trial based on the previous trial, like Paragon, HF, for the sacubitril/valsartan, it's just neutral result. TopCat for spironolactone, it's just like not show mortality benefit except for like North American people, and CHF like for pindridopil, this one also found a neutral benefit. But last year, Emperor Preserve, this is empagliflozin compared to placebo. So I just want to talk about this study a little bit. So this one is a randomized double-blind placebo-controlled trial. They include patients with ejection fraction 40% or above, and this patient also have elevated pro-BNP. Patient can be like diabetes or non-diabetes, and the the key point, they compare between empagliflozin and placebo here and look at the severe death and hospitalization. Look at the characteristic of the patient here. You can see like we have diabetes like half of that patient in both group, and ejection fraction like between like 41 or more than 60. And medication that they received is quite good, and you can see it still look like real world data like aldosterone antagonist. We just use like not much. And endpoint, you can see here, the primary endpoint, we found 21% reduction of death from cardiovascular cause and hospitalization. Look at the number needed to treat, around 31. And you can see here, if we look at the effect, you can see so early, around maybe, I don't know, less than 1 month from here, that you can see the separation of this graph between placebo and empagliflozin. And look at the primary endpoint in the individual component. The mainly of the composite outcome driven by the hospitalization from the heart failure, like 25% reduction of the hospitalization from heart failure from this medication. And if you look at the subgroup, and also the same, like you can see the diabetes or non-diabetes is also provide the same benefit. And the thing that you need to keep in mind that the benefit of SGLT2 kind of attenuated appear to be observed in patients with the highest ejection fraction. Like this patient may not get benefit when you have higher ejection fraction, something like that. And this is the secondary endpoint that they look at. And I just want to quick talk on this one. It's about the change on the eGFR that I already mentioned, that at beginning you may have a drop of eGFR here, and over time the decline of the eGFR just like lower in the empagliflozin group compared to placebo. Also, that's why in the heart failure with preserved ejection fraction in the guideline right now, they not put SGLT2 inhibitor in the guideline because the guideline just published before this study. So however, I would like to see in the future if the guideline gonna change or not. But right now for SGLT2 inhibitor, we recommend in patient who has diabetes, and this can prevent cardiovascular death for patient. All right, this is my last slide. I know it may go fast and it's like I need more time, but this is my last slide, and this kind of like take home messages. Any beta blocker or RAS inhibitor, beta blocker, aldosterone antagonist, and SGLT2 inhibitor serve as a foundation of pharmacotherapy for HFrEF patient. It's important to use the guideline directed medication therapy for HFrEF patient and titrate to maximum tolerated dose. We found that you can start medication at the same time. It's safe and effective, and that can help patients to get early benefit. And also, heart failure patient, you need to be routinely assessed and treat the comorbidity. And for SGLT2 inhibitor, maybe the first medication that improve CV death, and pharmacists also play a crucial role for that. I think that's all for my talk today. Sorry for late on this presentation. All right, thank you. I feel to open for the question later.
Thank you so much, Dr. Alilat, for your great presentation. You'll be still with us at the discussion session, aren't you? So I think it would be okay if anyone has any question and ask Dr. Alilat at that time, or you can leave your question at the chat box also. Now we are moving to the next session, Pharmacist role in heart failure in the Philippines. Our speaker is Dr. Charles Mandy Aaron. Dr. Charles got his Bachelor of Science in Industrial Pharmacy from College of Pharmacy, University of the Philippines, Manila, and doctorate in pharmacy from Faculty of Medicine and Surgery, University of Malta. Now he is a full-time instructor of the Department of Pharmacy, College of Pharmacy, University of the Philippines, Manila. Please help me welcome Dr. Charles.
Much, Dr. Tirapong, for that generous introduction. Can you see my screen now?
Yes, we can see your slide right now.
Okay, so thank you so much. So for the second part of the webinar, so I'm here to actually share with our colleagues the pharmacist's role in heart failure, particularly in the Philippines. So why is it important for pharmacists to be involved in the management of heart failure? So based on studies, we've seen that the involvement of pharmacists could actually prevent your medication related errors, such as in this study conducted in Netherlands, wherein they had the clinical pharmacist discharge system for heart failure patients. Second one would be it's also associated with a decrease in mortality through different pharmacist-led interventions like drug use evaluation, ABR monitoring, participation of pharmacists in medical rounds, as well as medication history taking. So apart from these clinical outcomes, the involvement of pharmacists could also have great economic outcomes by minimizing the total cost of care for heart failure patients. And apart from savings, our patients could also get educated for them to be empowered and hopefully manage their chronic condition under the supervision of a healthcare professional. So all in all, you have your economic and your clinical outcomes, which could translate, of course, to a better quality of life for our patients. So where are we exactly as pharmacists, no, in the management of heart failure? So your pharmacist, together with our patients and our different healthcare professionals, we're actually in the center of the transitions of care for our heart failure patients, wherein we have to ensure that they receive the proper management when they go inside the hospital and when they go when they get discharged in an ambulatory care setting. And how can we exactly take part as pharmacists in ensuring a smooth transition of care for our patient? So we have here quite a lot of roles of pharmacists that we could do in heart failure management. So we have here your medication history review and reconciliation, drug interaction management, dose titration and adjustment, safety and efficacy monitoring, medication adherence, referrals, and of course, patient education. So I'll be focusing on the roles of pharmacists, particularly in the Philippine setting. So I assume that most pharmacists who are present here are already, of course, aware of how we perform all those roles I presented earlier. So the succeeding slides will just show you some of the clinical pearls that we have to remember as pharmacists when we're doing those roles. So in the Philippines, when it comes to medication history review and reconciliation, we are making sure that if patients won't be able to tolerate your ACE inhibitor, they could be shifted to your ARBs or maybe through your ARNIs or your Entresto. And then we also have to make sure that patients who are taking non-dihydropyridine calcium channel blockers like verapamil and diltiazem, we have to reconsider whether they really need those medications as they could aggravate your heart failure. And then when it comes to the use of their diuretics, particularly when they combine your loop and thiazide diuretics, they could have a chance for having diuretic resistance. And we could consider maybe using a more potent diuretic in the case of metolazone. And then apart from that, we also have to check during a medication history review whether there are signs or whether there are information pointing to iron deficiency anemia in our patients, as this condition could actually aggravate more the symptoms of our patients, especially during exercise. And then the second role of pharmacists is through dose titration and adjustment. So as presented by Dr. Arirut earlier, most of our medications for heart failure, they would need to be titrated either every 2 weeks or on a weekly basis, such that we minimize the side effects that they could encounter at initiation. So we are using your medication titration plan for us to ensure that the medications are scheduled in a manner that the side effects could be minimized. And then third one, you have your drug interactions. Partly, this could be related to medication history review and reconciliation, since some of our patients could actually be taking ACE inhibitor together with ARBs plus potassium sparing diuretics, which could gravely result to hyperkalemia in our patients. So we have to watch out for this triple therapy.
I think Dr. Charles got his problem about the connection. So our technician will connect to him, and everyone can take a break for a few minutes right now. Okay, I think we should switch to the last session instead. And when Dr. Charles come back, we will let him to present his presentation again. And okay, for the last session for today is Pharmacist Role in Heart Failure in Malaysia by Dr. Wong Yi Xing. Dr. Wong Yi Xing, are you ready? Okay. Dr. Wong Yi Xing graduated from International Medical University. She got her master's degree of clinical pharmacy from University ASEAN, Malaysia. She got her board certified pharmacotherapy specialist in 2013. Now, she is the head of pharmacotherapy services unit of Pusat Jantung Hospital, Sarawak. Please welcome Dr. Wong Yi Xing.
Can anyone hear me?
Yes, and we can
Can you see my
also
slide?
see your slide right now.
Oh, okay, thank you very much. Hello, Sawadika. Hi, thank you, Dr. Tirabon, for your kind introduction. And thank you, MSU, for inviting me to participate in this webinar. It's greatly honored to me. So without further ado, let me proceed with my presentations on the topic of pharmacist role in heart failure from Malaysia perspective. Okay, this is where I work. This is Sarawak Heart Center. So I do welcome you all to come and visit my hospital one day in future. Perhaps you all can form a study tour. I will greatly welcome you all. Then this is my outlines of my presentation, where I'll be just touch a bit on the impact of pharmacists in heart failure patients' care. And I proceed with the role of pharmacists, and lastly, a conclusion just to wrap up my presentations. So firstly, let me just share some of the evidence-based significant impact of pharmacists in heart failure patients' care. Heart failure, as mentioned by a few of our speakers before this, that is a chronic, severe, and a complex disease which result in multi-system dysfunction and increase in mortality rate. A multidisciplinary team approach is the standard or the gold standard of heart failure care, and the pharmacist is indispensable in the team. So research and systemic review conducted throughout the years have actually shown that by involving pharmacists in the heart failure treatment actually can improve patients' care with earlier achievement of the guideline-directed medical therapy, increase the percentage of patients achieving optimal ACE, ARB, beta blocker, and also the new SGLT2 dose, higher chance for them to receive heart failure educations, and of course the most important thing is to decrease in all-cause hospitalization and decrease in the all-cause mortality rate. So what are the exact role we as a pharmacist play in the heart failure patient's care? I have listed down a few, which is include assess, review, counsel, and dose adjustment. These roles are more applicable in the outpatient clinic setting. In my hospital, our heart failure clinics run every Tuesday, and during the clinic day, pharmacists will sit in together with doctors to see patients. Our role or our duty were very much guided by the protocol published by our pharmacy division under the Ministry of Health, Malaysia. Most of our patients actually, they come to the clinic and they will see the pharmacist first before they proceed to see their doctors. So during this time, pharmacists will actually assess the patient with the following points. If the patient are new to us or they are first timers, we will usually assess their past medical, surgical, and family history. Because as we all know that most of our heart failure patients, they actually do come with other health problems or other comorbidities. And some of the health problems actually will sort of affect our treatment later on. For example, if your patient have uncontrolled asthma, if your patient have this condition, then we might need to be extra careful or extra cautious when we want to titrate up our beta blockers. We will also assess patient, does patient have any allergies to any food or drugs? And of course, we will avoid the allergens. We will look into patient's social history, their education level, their family backgrounds, because somehow or another, these are few factors that will affect patients' compliance to treatments, compliance to medication, as well as follow-up. We will look into the patient medication history, which I think this is one of the most important criteria that we'll really need to explore thoroughly. Like I mentioned just now, heart failure patients usually have other comorbidities. This means that besides heart failure clinic, they might be going or visit a few clinics in other hospitals. Therefore, when we look into or when we do the history assessment of the prescribed medication, we have to ensure that the medication list is complete. Complete in the sense that we need to get all the medication that a patient is taking either from the heart failure clinic or actually from the other clinics. Besides that, we also ask or assess patients whether they are taking any herbal, any traditional medications, any supplements, or any over-the-counter drugs. As for supplements, we are very concerned on they are taking some of the unregistered product. You know, nowadays, there's a lot of products that they promoted in Facebook, Shopee, and all that. And we're worried that they might be taking unregistered product. And I have a few cases in my hospital where patients was admitted due to heart failure. It's because they're chronically taking some of the unregistered supplements, which when we tested, actually they contain a high dose of NSAID rather than the natural products claimed by the supplements. Then we will go on to assess patient's knowledge and understanding on the disease and medication, and this will affect or fine-tune our counseling section later on. Last but not least, we will assess the patient's compliance, where we will check whether the patient taking the correct dose, correct frequency, and is it taking at the correct time. One of the common scenarios that I encountered during my clinic day is that, for example, a patient, they are taking, maybe I give an example, bisoprolol. The doctor from the last visit already asked him or her to take 1 tablet, 2.5 mg per se, increase from half tablet to 1 tablet. But when we assess them, actually patient might be telling you that he or she is still taking half a tablet. The reason can be because patients too used to the old dose. They didn't realize that the doctor actually increased the dose. This usually happens to the elderly. So therefore, we really need to ask every or each one of the medication how they are taking it. And sometimes your patients are not compliant. They do not take their medication. It's not because they did it on purpose. It's because they might be experiencing some of the adverse effect or side effects. For example, it's quite common for patients having dry cough if they are taking ACE inhibitors. And I do have some male patients that actually experience swelling and enlarge of their breast after taking spironolactone. So during this assessment time, we actually spend times interviewing and interacting with patients, trying to find out what is the difficulties they're having while taking the medications. And we try to record it down and discuss with the doctors. Besides assessment, we will do some review as well. We'll review the patient vital sign as well as some of the lab investigation performed or done during the clinic days. Vital signs and lab investigation, actually they are a way that to reflect. In that scenario, we will record it down and discuss with the doctors. Perhaps during that visit, we will not increase the dose of beta blocker yet because patient actually are not taking the correct dose and the heart rate actually did not really reflect the efficacy of the medications. Yeah, as for lab investigations, if your patient is on ACE inhibitors, ARB, ARNI, or like furosemide or any potassium supplement, spironolactone, then we will have to monitor their creatinine, their renal function, as well as their potassium levels. Full blood count or coagulation profiles is provided if they are on any antiplatelets or any anticoagulations. Liver function tests and lipid profile if they are on any statins to reduce their LDL. Of course, the lab investigation, there is more, but these are the common ones. Once we've done with the assessment and the reviewing, then we'll proceed to discuss with the doctors on any of the significant lab investigation results as your creatinine clearance or any drug-related side effects experienced by the patients or any compliance issues that we found out, or we will advise doctors on the potential drug-food, and drug supplement interaction. We will either discuss with doctor face-to-face. If we cannot do that, then we'll record it down and the doctor will read our review. Usually assessment and review is done prior patient to see a doctors. So after patients see the doctors, have reviewed by the doctors and have adjust the treatment plan, then they will come back to us again for counseling session. So if they are new to us or first timer to the clinic, then we will proceed to use our simplest language to counsel them on what is heart failure, what is this disease is about. That's why we need to know about patient background first so that we can fine-tune our counseling session. Because no point we go on to use a lot of jargons if your patient don't understand. Then you might be wonder why patients need to know about disease. They are not doctors, they are not pharmacists. They should just know their medication and take it. Why they need to know about what they are having? But by empowering your patient to co-manage their health problems, like in terms of knowing what they're having, knowing what the symptoms they're having, and of course know their medication, actually will help them to achieve their health goal much more earlier and faster. This is especially in heart failure patients. Because in heart failures, their quality of life is muchly affected. Can you imagine if you can only allow to drink 500 ml to 1 liter of liquids per day, or you cannot shower on your own in severe cases, or you cannot climb a staircase without feeling breathless. This is very depressing. That's why we need to let them know why they are having all this, what happens to their heart. And with that, then we link them to the importance of medications, how the medication will actually help them to improve their quality of life, to make them feel better. For example, like furosemide will help them to prevent their legs from swelling or water in the lung or edema. ACE inhibitors, ARB, or ARNI will actually help to preserve their ejection fraction, improve or reduce their hospitalizations. Beta blockers, again, will help them improve their symptoms. Then from there, we also emphasize again on the compliance to medications and the consequences of not taking medication as well. If during the follow-up, there's a changes in dose, changes in frequency, and also changes in medication list, such as added in new medication or remove the medications, then we will be very specifically pointed out to the patient on what are the changes. And we have to make sure the patients or the caretaker actually understand the changes before they left the room. And often if we know that the patient is a smoker, we will try our very best to talk them out to quit smoking. If they do have the wish to stop smoking, then we'll refer them to an appropriate clinic, smoking cessation clinic. And sometimes we do need to counsel patient on furosemide regime. This apply when the doctor actually prescribe on furosemide, tablet furosemide 40 milligram or 20 milligram PRN or when necessary. One of our counseling point is that when the patient need to start taking furosemide, we need to teach them. So sometimes, not sometimes, sorry. So one of the counseling point is that if their body weights increase by 2 kilograms within 1 or 2 days, that is the time where they need to start their furosemide. And they should stop it when their body weights actually reduce to baseline. This is an example. So actually our heart failure patient, we require them to weigh themselves first thing in the morning every day. So these are some of the counseling points that we used to give during the session, but these are not all the counseling points. There are actually more. So in the protocol, actually pharmacists do allow to do some dosage adjustment only if the local policy and the head of department grant us approval. And the letter of authority must be obtained before we can do any dosage adjustment. And the name of the pharmacist and the list of the medication that can be adjusted have to be stated clearly in the letter. So here are some of the images. Here, this is the pharmacy clinic. Oh, sorry, the pharmacy room in the heart failure clinic. This is my colleagues and these are the patients. So this is where we perform our assessment, our review, and our counseling. You can see during the pandemic, we're practicing social distancing. You know, we are all face on, and face shield on, and all that. So this is where we carry out our activities. This is basically a file there where we put in all the samples of the medication that are commonly used in heart failure clinic. This is useful for us to assess patients' compliance to medication, especially if they did not bring their own medications. So this is a hard copy. And we have a soft copy here where we using an iPad and we upload the images of the medications. Here are some of the documentation we used for our activities. Here you can see we will record down the patient's profile, their allergies, their medical history, their social history. Here is some of the lab investigation during the during the clinic days. Here is the most important part, the medications. And if we have any issue found, we will record it down here. So if we're unable to face the doctors or talk to the doctor face to face, then the doctor will review our documentations. Yeah, so here I come to my conclusions. So for those pharmacists or the future pharmacists in the group here, my future colleagues, yeah, so for if you all wish to become a heart failure pharmacist, then here's just my little advice. Try to equip yourself with knowledge during your uni year. These 4 years is the best time for you to equip as much as knowledge you can. And of course, not to forget to continue learning after you graduate and gain the experience from the training offered by your hospital, offered by your department, or offered by your government, or countries, and also gain the experience from practice. When you see more patients, you get to know them more, and you will know how to give the best care to them. And most importantly, you have to have the sincere heart to care for your patient. And then with that, I think you will be ready to play a good role in taking care of our heart failure patient and actually any other patients. Okay, so with that, I'll end my presentation. Thank you for listening.
You make us seeing picture about our growth clearer. And now we switch back to Dr. Charles. Glad to see you back and sorry for skipping you.
I apologize as well. All right, so I apologize because it's actually the release of the election results here in Malta. So the internet connection is kind of busy. So I think earlier I've stopped in the drug interactions, particularly on the importance of looking for the triple therapy, which could cause hyperkalemia in our patient. So going through, so we're also involved in safety and efficacy monitoring for our heart failure patients, particularly for those on ACE inhibitor and ARBs. So we're trying to look at blood pressure control, angioedema, the presence of dry cough, and also whether our patients are pregnant or not. And then another one, when it comes to safety monitoring, we also have to check for the electrolytes and the renal function of our patient. And if there are also symptoms of overdiuresis in our patient, as can be seen by dry mouth, thirst, abnormalities in the BUN creatinine ratio of our patient. And then when it comes to the efficacy, we try to look at the improvement in volume overload of our patient, particularly if there are changes in their weight, etc. And then for patient education in the Philippines, particularly in my university, we've actually launched the telepharmacy service, especially during the pandemic, wherein we've had limitations meeting our patient. And we've actually received a lot of queries, in particular with the novel medications like your Entresto, ivabradine, and your SGLT2 inhibitors, not only from our patients, but also from our other colleagues from other health professions. And then in terms of patient education, we also try to highlight in our patients, just in case that there will be initiated with a beta blocker, that they could experience an initial worsening of their symptoms due to, of course, the negative inotropic effect of the class. And then also for patients who will be using compression stockings who might be at risk for atrial fibrillation, we try to measure and also to teach them how to use their compression stockings, particularly in the community pharmacy settings. And then when it comes to medication adherence, we always try to tailor the medication scheduling with their lifestyle. And they could also use the self-management diary and the My Heart Failure Action Plan, the same way as how we use the asthma action plan for our asthmatic patients. So this is just an example of the self-management diary wherein they input or they record their physical activity, the level of their tiredness, what are the drugs they are taking. And the next here is an example of the heart failure action plan. And primarily, we try to empower our patients on how to manage their heart failure based on symptoms like weight gain or probability of overdiuresis in their case. So in terms of our referrals, we try to assess, especially in the community setting, if our patient are undergoing ongoing chest pains, if they have problems when it comes to their oxygen saturation, and if they've had a recent history of syncope or pre-syncope. And then I just added the setting here in Malta. I know this is out of scope, but in particular, I have two objectives for this one. Number one is maybe we could also use this practice for us to have a benchmarking with what's happening outside our region. And the number two, to also emphasize that pharmacists could also take social, administrative, and regulatory roles, which are also effective when it comes to improving the health outcomes of our heart failure patients. So particularly in the last 4 years, I've spent my time in the medicines approval section of the Pharmacy of Your Choice scheme here in Malta, which is like a sort of a national university healthcare. And they aim to provide free chronic medications for our patient. And in particular, we, as pharmacists there, I try to approve their medications based on the formulary listing as well as a government protocol. So an example of a government protocol which ensures the safety of giving metolazone for our patient is listed in this picture. And then for the formulary listing, pharmacists are also involved in making sure that the evidence are adverse drug reporting and causality assessment. So here is an example of the ADR report forms in which we encourage our heart failure patients as well as healthcare professionals to send ADR reports just in case they experience one. No? So here they try to input all their medications, and the pharmacist's role is to assess if there are any causalities between the medication use as well as the adverse reaction that they experienced. So that's it for my presentation. Thank you so much for listening, and I hope you learned something from this lecture.
Thank you so much, Dr. Charles. Okay, I think we don't have enough time to do a big discussion, but just a few questions is okay for our speakers. And does anyone has any question or has any experience to share with us? Maybe I will be the first one. Okay, I would like to ask our three speakers that do you have data about using flexible diuretics that patients can adjust the dose of furosemide themselves? Does it reduce mortality or hospitalization, or just work for symptom reduction only?
Maybe start with myself first. For the flexible diuretics regimen, I think I have experience during like my practice in the US, but in Thailand, I for myself, we rarely use this strategy in local hospital, like in the community hospital, but in a big hospital in the city, many doctors use this strategy, and that's quite common. And the big thing that for this one is so important for patients to understand how to use this protocol. That a big challenging like for patients and for healthcare providers as well. But it's good to at least you try to minimize the dose of diuretics. You will not use like too much, and try to help patient to balance fluid balance for them. In terms of mortality benefits for diuretic, is still just help for symptom relieving. It's not like provide any mortality benefit. That for my experience.
Thank you, Dr. Apple. And Dr. Charles or Dr. Wong Yixing, do you have any experience on the flexible diuretics to share with us?
Dr.
Oh, Dr. Charles, you go first.
You can go ahead.
From my hospital, actually, we for the flexibility of furosemide regime, actually we see patients. It depends on the patients. I mentioned just now, we have to see whether our patient education level and how much they're understanding on the furosemide regime. Only then we will allow them to self-adjust. Yeah, if we deem that they are clear enough, they are sure enough on their what they're happening to them, and they have the ability to weight themselves every single day early in the morning, and they are being able to comply or follow instruction, only then we'll allow them to self-adjust. Because too much of diuretics, like Dr. Apple would say, actually it will bring more harm than good. So even though it's in tablet form. So that's why sometimes we do what we on the furosemide regimes, besides telling them when to start and when to stop, we also actually tell them when they need to see doctors. No, yeah, because most of the time when in my hospital, what I can see that actually they drag themselves when they can no longer um live their normal life, you know, when they have to sleep sitting up, only then they're willing to go to hospital. Maybe most of the time because nobody likes to go hospital, unfortunately. You see, they might be still working, so they cannot just you know, keep on going to hospital, visit emergency. I mean, this is life, right? So that's why sometimes they will just drag themselves until they can no longer then can no longer tolerate, only they come to us. And unfortunately sometimes it's too late, and usually this will prolong their hospitalization. We need to use a lot of diuretics and slowly to flush out the water inside. So that's another point that I usually tell my patients: don't come too late. Please, if the tablet furosemide doesn't work for you for 2 to 3 days, you're still having leg swelling, your weight doesn't go down, please come to the emergency. Yeah, this is usually what we do. But like I said, unfortunately we have to select patients because it's dangerous also if they just, you know, self-titrate furosemide. Yeah.
Thank you. And Dr. Charles, what do you want to
I've
share?
actually had experience of the flexible diuretic dosing here in Malta, but not really in the Philippines. I've seen patients who actually appreciated the approach, since they feel that they are more empowered in terms of taking care of their health. But at the same time, as emphasized by Dr. Wong Yi, we really have to select who are the good candidates for this approach, since I've encountered patients who really did not understand how the approach works, and then the tendency is that it's a little bit too late before they go for emergency help. And I often see benefits of this approach in patients with HFrEF, but for patients with preserved ejection fraction, usually I did not see that much benefits from using the flexible diuretic regimen approach.
Thank you so much, Charles. And we also have questions in chat box from Ms. Vanloni Sibunhyang. How do you follow up your patient compliance? Do you use pill count? Maybe ask Dr. Charles or Dr. Wong Yi.
Okay, I just realized just now I didn't turn my videos on. So sorry. For assessments right in Malaysia, we actually, for pharmacy side, we do have a scale. Actually, it's like a 13 questions, 12 questions of a question for them to answer, or we interview them based on that question, and from there we'll assess their compliance. Maybe it's something similar to Morisky scale. Maybe Morisky scale is more familiar to the other countries. Yeah, but it's something similar to that. Yeah, so we do have, that is one of the tools that we use to assess patients' compliance. Pill counts can be one of it, but we don't really use that much often in heart failure patients. Yeah, we use pills count for other types of patients, yes. But we will just focus on the questionnaire that we use. Yeah.
Thank you. And another one question is, what are the current non-pharmacologic interventions applied in the management of heart failure? Maybe Dr. Apple can share with us.
Okay, so for non-pharmacologic treatment for heart failure patient, I think the big one that we really need to talk to patients since patient develop heart failure already, and the thing that we really educate them is about weigh themselves quite often, like to check the fluid status, and that can help at least prevent some type of like worsening heart failure, and that they can know how much fluid they have in the body. And other stuff that we also educate them in terms of like try to maintain salt intake. So like even though like you stay in community many times, like especially in Thailand, in northern east of Thailand, we have many food that contain high sugar, high salt, that also put patient at risk for maybe like fluid overload. And especially another thing that even though it's not related to non-pharmacologic, but I think medication, like Dr. Wang Yixing mentioned too, is like medication review is so important, that I think is kind of like a help to check if medication that patient taking can exacerbate heart failure, for example, NSAIDs, steroids, something like that. And other than that, I think we just try to help patient to understand about the risk management. I think like if patient has hypertension, diabetes, dyslipidemia, you need to talk with them about that and try to help to manage blood pressure or something like that. Yeah.
Thank you so much, Dr. Apple. And okay, I think we get to the end of our webinar right now. Thank you everybody to joining us today, and don't forget to fill in the forms that we will send you to your email to get a certificate and to get CPE credit for Thai pharmacists also. And the last one, I would like to promote our postgraduate curriculums in both master degree and PhD in Mahasarakham University. We are pleased to inform you that we welcome all international students. If you are interested, please go to our website to see more information. And for today, thank you everyone, and see you again next webinar. Thank you so much.
Thank you.
สวัสดีครับ
Thank you.
Thank you. Have a good day.
Thank you, Dr. Charles and Dr. Wong Yi Ching also. Thank you.